Good afternoon, everyone. Today, 10th October 2020, marks the World Palliative Care Day, a unified global day of action to celebrate and support hospice and palliative care around the world. I'm Inishu, moderator of today's international webinar on coloring last days of life with tender love and care. Welcome you all and wish you a happy World Palliative Care Day. Before we begin, I'd like to shed a light on the meaning behind today's event, World Palliative Care Day, a day dedicated to raising the visibility, awareness, and understanding of palliative care within the global community and to providing opportunities to support hospice and palliative care in the form of a unified day of action. The word palliative means relieving pain without dealing with the cause of the condition. And according to WHO, palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life threatening illnesses. Everyone has the right to be cared for in the way that best suits their needs, and this day emphasizes just that. That is, a right to high quality end of life care, and that more needs to be done to enable everyone to access it. Now I request Mr. Vikram Chaudhary, Director and Founder of Operant Pharmacy Federation, to share a few words on today's event.
Yeah, thank you, Mini, for the introduction. Palliative care, my comfort, my care. This theme this year to everyone has the right to end of their life with dignity, respect, and freedom from pain. When a person died, then a multidisciplinary team of health workers care about a patient. It is a day how to give colors to the life of patients because patients
Vikram, you don't put what's in there. Yeah, thank you, Vikram. You're back.
but about the other days, how to make rest of the days colorful in their life. Palliative care is the quality of life patients and their families facing the problems associated with their life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessments and treatment of pain and other problems by physical, psychosocial, and spiritual. We want to give attention to the young generation. They want attention from them to their advent future care about their help and care is applied through relationships that provides insights into each individual's unique situation and needs. Evidence and research will continue to help us understand which therapies will help the patient care. The emergence of integrative medicines of care that integrates conventional and allopathic medicines therapy with modalities not typically introduced but conventional care and address the physical, emotional, and spiritual needs of patients. On this World Palliative Care Day, we will be having renowned speakers with us. They will guide you how we can prevent or how we can help us to our palliative care. Thank you. Over to Minishi.
Thank you, sir, for the brief and appropriate introduction on palliative care. I request you, sir, to turn the time over to the first speaker of the day, Dr. Sneha R. Rambani.
Before that, Mini, I would like to say a few words.
Everyone has the right for the end of their life to occur with dignity, respect, and free from pain.
Would you like a drink of water, Dad?
When a person decides they want to die at home,
When a person decides that they want to die at
which
home,
includes the home
the
care
multidisciplinary
worker,
team,
enables
which
this
includes
as
the
far
home
as
care
possible,
worker,
medically,
enables this as far as
emotionally,
possible,
and spiritually.
medically, emotionally, and spiritually.
You understand that he's been quite clear about not wanting to be resuscitated. I think we should honour that. Yes, we do. I think we're at that stage,
The
Joe.
most important role of
the care worker is to provide direct care to the person who is actually dying and to provide reassurance to all people who love that person and to give them emotional
They can be
support.
surrounded by
So they can be
the
surrounded
things that
by
they love,
the things
their
that they love,
intimate
their
surroundings,
intimate
and they're with
surroundings,
family and
and they're
friends.
with family and friends.
Looking back, it
Looking
means so
back,
much
it
to me
means
now
so
to have been
much to me
involved in
now
his
to have been
care
involved in
alongside
his
the
care
nurses.
alongside the
The care
nurses.
team were
The care
incredible.
team were
They
incredible.
made sure Dad's
They
wishes
made
were
sure
followed
Dad's wishes
according to
were
his
followed
advanced
according to
care
his
planning.
advanced care planning.
Hi, John. Thank you, Mini, for the lovely hi, and thank you for the lovely video. The video says it all. Today, I'm so blessed that when Open Pharmacy Federation, the founder, Vikram, had asked me about World Hospice and Palliative Care Day, and I immediately agreed and I said, yes, Palliative Care Society of Bangladesh would like to join hands with Open Pharmacy Federation because we need to spread a strong message globally that my right is my comfort, my care. So let me begin by saying, let's add life to days rather than days to life. Often, palliative care, the word palliative care is and hospice is very depressing. We think it's about death, dying, and there's another word, donation. But today, I have very thoughtfully having this webinar with the title "Coloring the Last Days of Life with Tender Love and Care." I want to replace the death, dying donors with C. I want to bring colors. I want to bring care. I want to bring compassion. And I want to bring comfort to those patients who are suffering from life limiting, incurable disease. You need not die every day when you have a disease like that. You die only uh, when death comes. It takes about a few seconds. But what about the life that you will be leading before your death? It should be with full of comfort. It should be a life full of love, tender, and care. So I'm so pleased here to have with us Dr. Sneha Ambwani, who is the HOD of the Department of Pharmacology, AIMS Jodhpur. We have Professor John Robertson, who is a surgeon and holds a wonderful position in the university. And he's continuously working on cancer, how to prevent, how to treat. We will hear his story. Then there's another personality which has not been able to join, Professor Nizamuddin Ahmed. We call him the father of palliative care in Bangladesh. There is some problem with his computer, but we have another personality with us, Dr. Nadia Binte Amin. She works from a women's platform empowering women, and we will hear everybody's story. So it should be very engaging. We will take out depression from this webinar. We'll take out the word death. We will celebrate life and how can we create a compassionate society. Thank you. On to Dr. Sneha Ambani. Will be introduced by Vikram.
Vikram is not on the line.
Then he's coming back.
Yeah.
Vikram, you need to introduce to Dr. Sneha Ambani.
So please unmute.
Yeah, thank you. Sorry for the connectivity issues. Now I would like to introduce Dr. Sneha Ambwani. Dr. has completed her MBBS and MD and currently working as Head of Department of Pharmacology, All India Institute of Medical Sciences, AIMS, Jodhpur, Rajasthan. Now I would like to invite Dr. Sneha Ambwani for her talk.
Thank you, Vikram. Thank you, Dr. Zareen, Dr. Nadia, Dr. John. Thank you very much to inviting me on this platform where I'm sharing the screen with dignitaries, well-known dignitaries. As Dr. Zareen and Dr. Vikram said, this is the palliative care is for all those patients which are should not say, but waiting for their death when they are having some life-threatening diseases like cancer, AIDS, and more neurological disorders like multiple sclerosis and all that. So they are waiting for their death, and it's not only about the patient; it is about their families also. Their family is also suffering with all, they are going through all the pains and which a patient or his or her relative is going through. So it's not the care of patient, it's a care of patients and his or her family, and give a good quality of life, I must say, during on those days. And as I also experienced, one of my close relative, she was having this cancer, and it's a very painful condition she was facing in last stages of her cancer. She was having pain, and in spite of our all efforts, we tried our level best, but that was long back. It was almost 20 years back. On those days, these palliative care was not in much action, especially in India. But nowadays we are having so much of drugs and methods, so which we can improvise the quality of patients suffering with these life-threatening diseases. Now, as you know, the most common symptom or most important devastating symptom of these patients is pain. Another is they are having anxiety, insomnia, fear, depression. These are the most common symptoms of these patients. And not only the patient's relative, patient family members, they are also in fear. They are fear of what will happen next moment. So a holistic approach should be there while treating or while consoling these patients. As this title of or theme of our webinar is fulfilling the coloring last days of life with tender love and care. So all these patients, they are requiring attention, a little bit of means communications and care. And as you know, being a pharmacologist, I know that the pain is a very devastating, I must say, symptom in all these patients. And to treat these pain, we nowadays there are so, apart from drugs, there are so many other alternative methods are also there to relieve pain, like meditations, yoga, these acupressures, and all alternative therapies are available. So we have to give this care to all these patients. And while giving any painkiller, we should be keep in mind all these drugs which we are using for pain, they are not devoid of any adverse effects or side effects. So keeping in mind, we should give these patient these drugs starting from like simple paracetamol and these NSAIDs must be knowing, and then go through with the or escalate as the patient improves. And one important thing is with these patients is this is the palliative care, and that is different from the curative one, curative treatment. And it is a tailor-made, it's a tailor-made or individual this patient this individual customized or individualized depending on the patient's will actually and patient's response. That means if one patient is comfortable with a small dose of, for example, this paracetamol or iron drug like NSAID, ibuprofen or diclofenac, other patient may not be relieved by that drug. So we have to escalate or we have to start with other drugs. So it's not it's a fixed pattern of treatment or care of all the patient. तो कहते हैं ना एक छड़ी से नहीं हाँक सकते. We have a different yardstick for different patients. So individually, we have to take care of patients depending on their need. If they need higher doses of analgesic, for example, to relieve pain, we should give him. We shouldn't allow him to suffering with pain. If he's not relieved by, so stepwise, as I mentioned, stepwise approach should be there. If they are not relieved by small doses or non-opioid drugs, able to relieve the pain, we should go for higher one. And another approach to these patients, it should be the round-the-clock approach. Usually these painkillers and all that are given when you feel like pain. That is not appropriate for these patients. We should keep these patients round the clock free from pain. And if you know, if some adverse effect, depending on the patient situation, conditions, supported by the diagnostic features and all that, if you know that if that particular drug might cause some another symptoms, like for opioids, it causes vomiting. So it is better you give him an antiemetic prior, so that it shouldn't like that pain, so it relieve the pain, but simultaneously is also having vomiting. So its holistic approach should be there. It should be compact one, so that it's not free from the pain. Patient is not only free from the pain, but also from the other symptoms. Another important devastating symptom in these patients is anxiety or fear, or insomnia because of fear and anxiety. So we should also prescribe or give some good sedative, so that he can at least sleep for in the night for at least for 6 to 7 hours. So if he'll free from pain, definitely it will also help him or enhance the sleeping hours. If he's in pain, then he will not able to sleep by good, shouldn't have, will not have the good sleep. So that holistic approach should be there. So for pain, if patient is having pain and have insomnia, fear, anxiety, so it is always better you give some opioid analgesic. There are some mild opioid analgesic, must be knowing, that is tramadol and all that. They are very quite commonly used for these patients to relieve pain. So that not only relieve pain, that also relieve anxieties to some extent and also causes sleep, right? So that will improve the quality of life, so that patient can be pain-free, have a good sleep in the night and fearless. Simultaneously, as the main theme is give tender love and care. So care is also very important by the family members. They should talk them, they should give attention them, and they should, I must say, change their lifestyle or I mean quality of life depending on their patient, so that the patient becomes happy. Not only patients, it is a cumulative means patients, family members, they also keep themselves cool and calm. So that doesn't, a very famous movie is there, Anand, which have seen most of, might have seen that. Rajesh Khanna and Amitabh Bachchan, they were there. So Rajesh Khanna says कि मैं आपकी आंखों में रोज अपने आप को मरते हुए देखता हूँ. Like that. That shouldn't be like that. patient family members also keep them cool and happy, so that patient himself didn't means feel guilty, like because of my life, because of me, these my family members are suffering. So that is also a good care which has to be, it's my opinion, given to the patient. They should give a good communication and good happy life to the patient by keeping themselves happy and relaxed. They shouldn't be panic. So that is how we can give the good care. Apart from pain and all these, there are other adverse effects and other symptoms are also there when patient is having any terminal illness like cancer and AIDS. As you know, in AIDS, good care should be there in because it should not suffer with other opportunistic infections, tuberculosis like that, which is very common in later stages of AIDS. And in cancer, there is sometimes patient is feeling anorexia, sometimes he's feeling constipation, sometimes there is diarrhea. So accordingly, we have to treat the patient. If there is any other drug which causes all these symptoms, first we remove that cause, and then we accordingly we have to give the treatment and treat these patients. For example, if patient is having constipation, laxative will give this improve the conditions. If patient is having anorexia, then their meals should be depending on their taste, and frequent meals can be given so that patient doesn't go into cachexia or the other devastating conditions or illness. So that is all holistic approaches should be there. And as WHO say, it is not only treatment, it is psychosocial and spiritual approach should be there. So that is all should be given at the same time to not only to the patients but to the family members also, so that patient can live a good healthy life. And it's not to intend is not to wait for death. It is not to hasten the death or reduce the lifetime. It's not the death. Let us happen the things in their own way, in their own cycle. So that is what I have to say that. So that's it. Thank you.
Thank you, Dr. Sneha, for your valuable and illuminating inputs on palliative care of both the patient and their families facing the terminal illnesses. Continuing further, I request Dr. Zareen Hussain, CEO of Integro Pharma Limited and General Secretary of Palliative Care Society, Bangladesh, to begin with the Q&A session with Dr. Sneha.
I don't have much question, but Dr. Sneha, as she rightly said, there are a lot of pain. So in palliative care, we say that there are 4 types of pain. One is physical pain, one is social pain, one is psychological pain, one is spiritual pain. So basically, you have to address 4 kinds of pain for them to have a better quality of life. I wouldn't say that, as I said earlier, that celebrate his life, not wait till he wait or hasten his death. Whenever we talk about palliative and hospice, we think that the person is dying and we are hastening the death. It's actually a misconception. We are not. We're trying to bring comfort to the patient as much as we can by alleviating the symptoms that's disturbing him. It could be pain, it could be constipation, it could be breathlessness, it could be anorexia, it could be anything. So just addressing the symptoms will make their life a little easy. And also, the patient should know, because in our culture, mostly the families, they don't want to tell the patient that what the disease is. But that culture should be broken. In European culture, American culture, the patient has a right to know. So today my message will be very strong that every patient has a right to know what the patient is suffering from. That way, it will not only give the patient a right to a right treatment, it will also give the patient's family caregiver to also know the desire of the patient. How would he want to live the last days of his life? So it is a desire. It is a desire. And my desire may not match with somebody else's desire. The family should not interfere. Let the patient be the focal point, and let there be a meeting with the family, with the patient, with the clinician, with the volunteers, with the caregivers as to what is best for him. not sort of if he cannot put a rice tube, okay, he's not having he's got a bowel obstruction, let's do a bowel surgery. No, let it be peaceful, let it be non-invasive, let him go peacefully. That is my thought. Thank you, Sneha, for coming up with the drug therapy. Today we know the gold standard drug is morphine, and morphine, we use morphine randomly, and it has no ceiling. It is still the gold standard drug. Now, um, uh, uh, I would like to invite Dr. John, Professor John, and here's a brief intro about him, which I will not take much time to introduce him. He is Professor of Surgery, Professor of Surgery, and also in Notting Hill University. And my question to John will be very simple. John, you are always, since you are into the oncologic surgery and you deal especially with breast surgery, so you are the icebreaker. And how do you break the ice when you have to tell a patient that there is a diagnosis, dash, dash, dash? How would you do that?
Thank you, Zareen. I think that it's a very important question, and one that has changed over the years here in the United Kingdom. And now I think virtually every patient, for example, who comes with cancer in the United Kingdom would be told their diagnosis quite clearly. And I would, for example, when they come with their primary disease, I would be very clear. We usually bring them with a member, ask them to come with a member of their family or a friend, and we would be very clear telling them that they have, first of all, cancer, and clearly that could be at different stages. It may be very curable, or it may be that they present with metastasis, and even at that point, that this is an incurable disease and that eventually they will require palliative care because they will die of their breast cancer. So those patients are told at the very beginning what their diagnosis is and what stage of disease it is. I think the other time is when patients have had curative treatment and then they come back subsequently with a recurrence and metastasis. And often that's a much more traumatic time even, because when patients come the first time, most of them know they have, in the UK, most of them know something is wrong. Most of them know and will say to you, yes, I thought I had cancer. So at that point, you're not really telling them something that they didn't know they had. The difficult time I find is often patients who've had potentially curative surgery and adjuvant therapy, where you've removed all the cancer, they think or they hope they're cured, but then it comes back again. And that can be quite a crushing moment, I think, for patients, where they realize that hope that they had, that they've now got recurrence of their cancer, which, while often very treatable, and sometimes treatable for many years, depending on the type of breast cancer it can be a very sort of devastating piece of news to give to patients. And so it's important how you give that news to them. We tell all of our patients the diagnosis. We tell all of our patients what stage they're at. Obviously, when I say all of them, that means they have to be of capacity to hear that. If they were demented or some other reason for not being able to take that information in, then that would be to the family you would tell them. But if the patient themselves is able to hear the diagnosis, then we would tell them and we would talk with them what that means, and again start to provide support for them. But even when they have metastasis, as I say, many of those patients with therapeutic treatments can live good and good quality lives for many years. So we're talking now about patients when they get to the end of life and the end of active treatment as such. But the point I would make is that over the years in the UK, that number has become quite, much smaller, thankfully. It's certainly in breast cancer. When I started about 30 years ago, patients, we probably saw 20-25% of patients presenting with either metastasis or with locally advanced disease. Now we've seen a shift to primary breast cancer, and so presenting with advanced cancer is quite unusual now in breast cancer. We probably see 5% who come with metastasis, and about 5%, maybe slightly more, who come with locally advanced disease. So the majority of our patients who die of advanced cancer are people who've had the disease as a primary cancer and then get recurrence, and subsequently, once they run out of therapeutic options, come to palliative care. I think the other big change we've seen in the last 30 years is just the amount of care that can be given at the end of life. And as you said, patients are no longer seen as simply treating their symptoms until they die. And now patients get, as you said, a holistic approach of looking after the physical, the social, their psychological and the spiritual issues and pains. But I think the other thing in the UK that's happened is that while palliative care is not completely taken over by the NHS, in the UK, a lot of the financial problems too that used to be associated with end-of-life dying have now also been subsumed into healthcare in the UK. And so, for example, you can die in mainly one of three places, either at home, or you can die in a care home, or there are hospices. But even the hospices in the UK are not funded solely by the NHS, and often they are supported by charitable funds and giving. But there are all these places where people can go to die and can choose where they want to die. So if you go to, for example, a care home, your GP, your general practitioner, will be the person with his team who will look after you. And if you die at home, the general practitioner will also be responsible. But if you go to a hospice, then there will be a team of palliative care specialists who will be responsible for looking after you and addressing your needs. And if you need specialist care, pain or lymphedema care, whatever that is you may need, then they will involve those patients too. So we've seen quite a large change in the number of patients with advanced breast cancer. We've seen a large change in the provision of that service, and I think also in the quality of the service in terms of both physical symptoms, but also, as you say, the other issues such as social, financial support, spiritual support, etc. Is there anything else you'd like me to talk about, Zareen? I can't hear you.
You unmute,
With breast cancer, they don't really come in a very advanced stage because you have this screening thing, the GP, they go to GP regular. But unfortunately, in our society, whenever, because of the cultural thing, they usually come with advanced stage. Now, do you recall any such incident in your life where you had to face that there was no treatment and there was no point in treating, where you thought that the treat failure or there's nothing else to do? Then what did you do? Did you sort of suggest palliative care?
Yes, I mean, what I'm saying is I've done this many times in the past, but I think it's becoming less common because I see people have been cured, more people have been cured. But this is something that faces everybody who looks after patients with advanced breast cancer. And so when I see somebody, for example, with primary breast cancer, again, what I'd be saying to them is that we are hoping to cure them. This is potentially curable. And then you have to get into a discussion about, for example, risk, what that means, what this is not a guarantee you can give them with your treatments, but it is, and it varies depending on the level of risk. It is a possibility that they will be cured or not cured, and you have to have an open discussion with them about what that means in their family. When they come with metastatic disease, I think it's a different thing. I always say to patients, this is a disease which currently is incurable, but it is treatable. And so they still have hope at that point that for some people, they may be controlled for a long period of time. People who, for example, have got hormone receptor positive breast cancer, on average, live 3 to 5 years now. but some of them can live 20 years if they've got very hormone-sensitive breast cancer. So on the one hand, you have to be clear and honest with them as to what their diagnosis is, but at the other time, you should not take away hope from them, because some of those patients may live a very long time. When you get to the stage that you were talking about, where you feel you've got to the end of active therapeutic treatments, then yes, you have to say to patients that you have no other options in terms of treating the cancer. And that can be possibly the hardest discussion to have with them, because it's not again that you're taking away all hope from them, because you can emphasize the palliative care that you can give to them. And so that is a very important thing to say, not simply to say, I can't treat your cancer anymore, but to say we can treat your symptoms and we can help you. But I think that we still have to understand that it is still a psychological blow to people to hear that. It's the worst thing I think they want to hear is there's no treatment for your cancer, because they know that means that they are on a pathway to dying, and that may be slower or it may be very rapid. But it is it's a huge psychological blow. It's a huge emotional blow, because many of these people have got family and loved ones, and they don't want to leave them. So I think yes, you do tell them, and I do tell them often, and so you have to be have empathy with that. You have to understand what you're saying to them. This is not just a moment that you pass on some information to them. This is a moment where you again change their life, the course of their life, and you change the perception of their life and the longevity of that. You probably change the dynamics of their relationship and their family and their friends, because they know that some of these they may be seeing for the last time, or very soon they'll be seeing for the last time. And so I think it's how you tell them, and it's also the fact that as far as possible, when you're talking about palliative care, you do give them as much support for that, so that the things that could cause them more distress, you can deal with as many of those as you possibly can, and to make the remaining life as stress-free and as fulfilled as possible.
Lovely. Thank you so much, Professor John. He is a professor of surgery, director of Center of Excellence for Autoimmunity in Cancer, University of Nottingham. Really liked your talk, because, as you said, people love to live with hope. So we are no one to break their hope. So we cannot say that it's not treatable. It's treatable, but then it's not incurable. So it's giving them hope that we can treat your symptoms and make your life, a quality of life, little better. So thank you, John. I must thank you from the core of my heart for joining this webinar, this beautiful platform. And now I would like to hear from Nadia. Nadia has just suffered from COVID. And, it is a pandemic that the whole world is facing. We are leading a new normal life by virtually connecting with each other. And when Nadia, she works from a platform to empower women, because she is the president of Women Entrepreneurs Association. It is a government body. And I would like to know, Nadia, when you had this COVID, you were in isolation, and you must have felt very depressed, and you perhaps could understand the mindset of patients who literally who suffer from life-limiting incurable disease, how lonely and isolated they feel. Though COVID is treatable, but that particular time you feel very lonely. So how did you deal with it? On to Nadia.
Okay. Thank you, Zareen. First of all, well, I would like to give show my gratitude to Dr. Zareen Delwar Hussain, General Secretary, Palliative Care, and Professor Nizamuddin Ahmed, Dr. Sneha Rambani, Professor John F.R. Robertson, Vikram, Sneha, everybody. Please thank you for giving me the opportunity. Actually, I am from a very social perspective person, and I will utter from my anthropological experience. But Zarinappa, prior talking to COVID, I would like to share. I have few
Yes,
stories to share
please do.
regarding my
Please do.
mother.
Yes,
Actually,
please.
if you could allow me. Okay. So my mother, she was. I lost my father when I was only 11 years old, and my brother was 4. Later in 2017, after suffering 11 years of cancer, my mother died in 2017. First of all, she was being suffered by lymphoma. Second, she had mastectomy. Third, she had tongue cancer. So I have been through 11 years of long slot, seeing her going through so much devastated pain and so much agony. So I had no idea about at that time regarding palliative care, but what we wanted to be, we always wanted to be compassionate, we wanted to be supportive, we wanted to always be being around with her all the time. But Dr. John, I have had a little question regarding my mom. When the third cancer occurred, like it was tongue cancer. So my mom, she didn't want to go for the tracheostomy, but the medical board, they were enforcing her. That is one agony I am carrying with me still, that what could have been done for her, because she did not wanted to go through that tracheostomy, and it really gave her a little bit of discomfort. But simultaneously, I will tell you one thing, that during this 11 years of suffering cancer, she was so lively. She was always used to smile. She never used to give us a feeling that she's suffering from going through so much agony. So I was also wondering, how could she manage to generate strength from within herself? That is another one thing. Simultaneously, she was not eager to take this tracheostomy because she just wanted to go like that. That was her last days, and from that I came to learn from her that within being a pain, agony, distress, and seeing end of the world, still you can be happy, and you can make people around you happy, showing a little bit of gesture with a lively smile and all that. So that is what I learned from her, being giving her compassion, giving love. I rather learned from her how to be happy at the end of the days, because death is a destiny, we cannot just avoid that. So that was one thing. And one thing she made sure, at her deathbed, she said that as you are working for the women, you should you have other businesses, so if you generate extra money, you should work for the women, uh, female, those who are suffering from cancer, mostly breast cancer, you should contribute to them. So these were her advice. This was a story about my mom, her 11 years journey. And yes, from her I came to I came to learn a lot, how to be strong and be passionate and restore my mental strength during my crisis. So recently, when I was being diagnosed by COVID, and I was seeing that people are just going like, they're just dying, they're just so I was feeling a little bit of isolated. But my mom came, somehow I was feeling finding her soul around me, and she was trying to give me sort of uh, palliative care support, confidence. So that brought me back, I think, that still if we can restore our mental strength, we can carry our life a little bit in a better way, in a more, yeah. So there are people, still people are good in this society, most of the people are good, I should say. That's how I found the doctors, nurse in the hospital. They were very much compassionate, empathetic. There are exceptional, there are people who are not neglecting their parents, elderly people, but mostly my experience, I think I should take positively from the support service, that people are really good. So still we can be hopeful, and palliative care, this new avenue you are promoting, and the worldwide it's being promoted, it should be promoted more, and it will encourage us to be more optimistic towards soothing death. That's how I feel. And if you have
I think
any
John,
question.
something. You asked John something. John, can we have your views about what Nadia said?
Yeah, I mean, would want to pick up the point you made about your mum having been offered a tracheostomy and didn't want it, and she had it. And I think it raises a very important point, which is about giving patients control of their treatment and of the palliative care. And I think that's hugely important. And I often say, sometimes a patient will say to me, I don't want that doctor, right? And what I would say to them is, let's talk about it. But in the end, you will decide, right? Nothing is going to happen that you don't want to happen. And so I think that's both in terms of therapeutic treatment, of treating their cancer, but also when it comes to palliative care, that they should feel in control of their life. And for most of us, we like being in control of our life. What we don't like is when our life gets out of control, like the corona pandemic, and people don't know what's going to happen, or they can't visit their relatives. And so I think you raise a very important point here about patients when they come to life-threatening situations, particularly advanced cancer or palliative care for cancer, is that you want to give them as much control for as long as possible. So I think if it had been myself and she'd said to me, I don't want a tracheostomy, I would have hoped to have had a discussion with her and explain why we thought it was good. But in the end, it is her decision to decide that or not to decide that. I think that's important. And the second point I would pick up on is just, how people are. Some people do convey smile, and other people are, I think, sometimes very sad at their lives as well, and we can help them as much as we can. But sometimes their life comes back on them either for good or not good. But what I've always found is it's amazing how women with advanced breast cancer, metastatic disease, do cope with some of these amazingly difficult and, from a point of view of personal experiences, quite terrible experiences from their life. And what often amazes me is that they're often more concerned about their family. Sometimes they're even more concerned about their doctors, and it can be one of the most humbling experiences to see patients as they come towards the end of their life, often, in fact, I'd say the majority of them, not so much concerned about themselves, but concerned about their loved ones and the people who are treating them. And I think that should also inspire us with the care that we provide for them. But it is a very humbling thing. And I think that it is something then that we can take and use positively in the care that we want to give back to them.
Thank you, John. Nadia, since you have a platform, Nadia, where you work to empower women and fighting for their right. Do you not think that my care, my comfort is also a right? Because what you want as a treatment should be your right. You should be the one to decide what treatment you will take. And should you not be talking about it, can we not expect that from your platform you will also talk about a patient's right, to care, a patient's right to comfort. It should be augmented. It should be spread out in order to build a compassionate society. Nadia?
Absolutely, absolutely. I feel in that with that. Absolutely. Thank you, Zainappa. Absolutely. We feel that we should have our own say actually what we should need for our at the end of the days or during our palliative care, what right we should be served for us. We should spoke out, we should generate awareness, we should disseminate with other female of the society, because there are still we have literacy lacking, knowledge lacking, so we need to generate awareness, and according to that they will decide that what actually they want for themselves. In that way, I think so. And finally, I would one thing I would like to tell you very positively. I don't know what happened after COVID. I am becoming very optimistic in life. I don't know. That's 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 a very. I feel good about that.
Because you're a fighter.
So I'm planning that after 10 years, how I would do gardening, how I would invite you with a very interesting way, treat you in a good table setup and all that. These things are coming into my mind, so I'm feeling good.
Good. So, Nadia, and thank you so much for letting us know about your journey with your mother. It is very inspiring that how you learn from your mother. And people have a misconception about palliative care, hospice. They think, oh, he's going to hospice means they are going to put him on morphine and then a morphine drip, and then the person is going to soon die. But this is not the concept at all in palliative care, neither in hospice. It is only giving comfort, only respecting the patient's wish, the family's desire. So that is how I look at it. Dr. Sneha, would you like to add a few words on that?
Yeah. I also would like to share something because recently in the last month only, my younger sister was diagnosed of breast cancer, and that was stage 3 directly. As Dr. John said, it's very difficult. It's very unusual. The patient comes in early stages, and I really have up to her. She's facing and means she's accepting that thing very positively, and it's now my duty to give positivity all the time. So that is what I'm trying to do. And she got just first shot of chemotherapy 2 weeks back, and next is due on the coming Monday only. So I want some support from Dr. John. If I would like to share her means discuss with this thing on the personal mail, if he allow me to drop a mail regarding her treatment and all that, if he allow me.
I'm happy to pick it up. I'm sorry to hear about your sister, and I would be happy to have a conversation with you. What I would say to you is, both you and Zareen have mentioned something, and I think that the word I would want to use here is balance, right? And so, for example, when you mentioned to me about positivity, I think we have to be positive, but the balance to that is realistic, right? In the sense that if I'm so positive that I'm unrealistic, if I say to every woman she'll be cured, very soon I will run out of being regarded as being truthful and run out of being realistic. So I have to keep positivity with realism. They want to know what's happening. And from Zareen's comment, the balance I would put from what Zareen said is that she spoke of everybody had rights. But we don't have a right to everything, she said. We've only got a right to certain things, right? And so, for example, if a woman comes to me and she wants an expensive drug therapy that I know will not make any difference, she doesn't have a right to that. Okay? And so our rights have to be balanced with our responsibilities here as well. And that's particularly true in terms of palliative care and in terms of cancer care. So I think as people listen to this, I think it's important that they don't think I can get anything I want, right? Because that's not the world we live in today. We have to be clear and we have to be realistic, and those rights will vary in different countries. For example, your right within the NHS in the UK may not be the same as your right in Bangladesh or America or whatever that would be. So I think there's context to this as well. But I'm very happy to pick up with you by email about your sister, and I'm sure Zareen can put us in contact outside the video chat.
Thank you, Ron. That's pretty much interactive. Vikram, I would like to ask you from a family point of view, what are your views about palliative care? Your federation, will it now work for my right, my comfort, additionally with what you are doing now?
May I just interrupt, Zarinappa, just one question to Professor John. Professor John, I just wanted to small question. During 11 years tenure of my mother's cancer, I was looking after her. She was being treated in Singapore, but during that phase, I was so much overoccupied with her treatment, with her taking care and all that. But I was absolutely lost. When I lost her, then I know that I lost her. You know what I meant? During the process, I was with her, I was taking care and all that. But when I really lost her, I found myself really lost. So is it a psychological crisis, or maybe I could not realistically I could not handle, or what? Is there any suggestion or any recommendation from you?
We've never met, so I don't know you in detail to comment. But what I think
I can answer her question.
What I think one of the things you're describing, right, is grief for somebody who you love very dearly, right? And so I remember reading a book by a professor from Yale whose son went skiing in Europe and had an accident and died, right? And he said, the grief of it, he said, is about the neverness of it, he said. He wrote, I could live with it if I couldn't see him for a year. I could live with it if I couldn't see him even for 5 years. Even if you said to me, you won't see him for 10 years, he said, I could live with that, he said, but it's the neverness that I will never see him again in this life, right? And I think that's the grief that people get. And so what I think when you say is I felt lost, I think what you may be describing, I don't know you, but I think what you may be describing is the fact that you realized that she was gone and you were never going to see her again. And that is a painful thing. It's a grief and it's a natural process. And so I don't think that you should view this as something abnormal. People have those grieving times, and sometimes it can last for many years, Sometimes it passes more quickly. Sometimes you find a way to adjust to that, or to deal with that, or whatever that is. But I think what you're describing here is a sense of acute loss. When you say, how did I miss that? So I think it's much more grieving.
Yeah.
Thank
Nadia,
you.
I mean,
Thank you.
It is like, as you're saying, the day you lost her, you felt that you lost her really, and you will never see her again. Yes, it is grief, and you need to grieve. You need to cry. Don't let your tears stop coming out. You must ventilate your feelings. There should be some kind of ventilation. You must. I mean, when we work in palliative medicine, we see a lot of death. And it's not that it does not affect us. We sometimes get so attached to patients that it does affect us. And there are times when we cry also. But it's okay. It's okay not to be okay. I mean, I'm a human being. I'm not a superhuman being that I'm a doctor and I will just see the death and it will not create an impact. And it does. And it's okay. It's okay to be okay. You know, there's a saying, it's okay to be not okay. So that's what I think. Vikram, I would like to take your views whenever I want to ask Vikram.
Zareen, may I add something to that?
Please, Dr. Sneha.
Same thing happened with my sister also when she broke with that news. Then initially she was normal, but when our relatives, my other sisters and brothers started talking to her, she becomes very emotional. Then she called me. They are talking me and now I become very emotional. Then I told her, this is not bad if you are crying sometimes. It's not a bad thing we are crying to listening to someone else. It's better you cry and open up. Cried out loud, like whatever you are having, your emotions, you show those your emotions. She talked to me for more than half an hour on that point. I told her, better you open up. If you want to cry, cry it. If you want to share it. And I want to share with because we were telling that the patients have right to know the things. So when I came to know this, her disease is because stage 3, and we are not able to conserve her breast. Like she's having on the right breast. So for a moment, I thought, should I tell her this is the thing or not? Then I decided to tell her the fact. So because she have a right to know what she is having, because otherwise she will be in a illusion that breast will be conserved and all will leave or may proceed for normal life. So I had a video conferencing with her children, my this niece and nephew. Then we spoke out for more than an hour. What is the thing and how thing will be proceed. Then we have to take care of everything, and we have to accept it. And with God grace, touch wood, she accepted it very well. Then I spoke it again on the next day. Have you slept well last night or not? Then she said, no, I accept the things and let us see. Let God keep all the things on the God. He will do the best. We will try our best and He will do the best for us. So that's
the spirit. I just want to say that we have 500 viewers watching this webinar. And even our ambassador from Ankara is watching, and then we have 500 plus viewers. So some of the questions that have come up to me is the palliative care, the palliative care that we offer in our country, in Bangladesh. I mean, not very many people know about it. And today, unfortunately, one of our speaker was the I would like to call him the father of palliative care, Professor Nizamuddin Amin. He could not connect. And since he's such a busy person, he had to sort of go to the other webinar. So he couldn't connect to me. So working with him was a huge privilege. And I feel so blessed because, when you work with patients like that, you get to see that how little things can bring joy to their lives. I mean, it's not about I could have invited a lot of industrialists to talk about donations and things like that. But there's no point. I mean, there is a certain point what money can do. What you can do, you can have empathy. You have to groom yourself with empathy. Today, as I would like to talk about palliative care is about quality of life. Death is inevitable. We don't know when anybody is going to die. But should a circumstance arise where you have a life-limiting, incurable disease, you should, your family should, your loved ones should sit together and plan your life so that you have a quality life. And as I said, like birth, when somebody takes birth, we do a lot of welcoming. So when the soul leaves the body, I think we should allow it a very nice transition. We should allow that beautiful transition to happen rather than resuscitate, put on the ventilator, as Nadia's mother had undergone tracheostomy. I don't think she would have wanted that. Even if I am a doctor, if I were to diagnose with anything third stage, I probably would want to live the way I'm living, not bother so much with so much of resuscitation and chemos and things like that. I want to go away peacefully because I want, since I am very optimistic. I want to be positive. At the same time, I don't want to do anything that will not give me comfort or not give me care. That's my point. And Vikram, from a pharmacist point of view, would you like to say a few things about palliative care?
Yes, ma'am. Pharmacists play a key role in the community. They can help to the patients by the self-medication, because lots of patients are taking the self-medication without discussing with the physicians and specialists. They are taking the medications. They are becoming the self-doctor, because as per WHO report, the many people are dying because of the self-medicines. So a pharmacist can play the role in the healthcare sector, and they can improve and they can suggest the patients about the palliative medications and what kind of medicines they can take, or they can prevent their lives. So pharmacists having a role in the community as well. Clinical pharmacists, they can also help their role to prevent these such kind of medicines. So, as compared to, we can say, clinical pharmacists having a key role in the palliative care. So they can improve the quality of lives of the patients, and they can bring
Quality of life.
very good,
Yes.
yeah. So they can spiritual of the patients, and they can help in the patients of quality of life. They can suggest the quality medicines, and patients can save their lives.
Right. Okay. John, one question I would like to ask you. What can you say about a patient's right? John?
What do you mean by that question, Zareen? What are you asking me?
A patient's right to know. I mean, culturally, you are
A
different
right
than
to know, I
us.
think.
Like
Right
we
to know, I think,
usually
is absolute. Yeah, no, right.
right to know.
The right to know, I think, yeah. I think every patient has the right to know, and I think that I say to people, the most important thing that I tell a patient, not that they're going to live, because everybody expects and hopes to live, but it is that they're going to die, right? And so patients have the right to know what their disease is and what the implications of that are for their life, both in terms of living and dying, but also the quality of their life as well. So I believe patients should be told and should be offered the information. I think it's also important because relationships are built on trust. Whether that's your personal relationship with your family or your spouse or your partner, or whether that's your professional relationship with your doctor or your lawyer or whoever it is, if you don't have trust, then that relationship is going to be eroded in some way and maybe break down. And so when Dr. Sneha said, she told her sister, could you imagine if she hadn't told her sister? She'd be holding a piece of information that she knows her sister might live her life a different way. And so therefore, it may not be a lie not telling her, but it impacts that relationship in some way. But if she told her, you don't have advanced cancer, this is an easily curable disease, right? Then that also impacts the relationship. So I think being truthful with people, whether they are your family or your patient, is really important, because that relationship is what they will build their life on. If I say to a patient about what their disease is, they're going to go and make decisions based on that. And so it should be based on the truth and should be based on the reality, right? Because as I say to patients, even patients who don't have palliative disease, palliative care, even patients who come with primary breast cancer, where they've got different risks of the cancer coming back, people might live their life a different way depending on what the level of their risk is. And so you can affect people's lives, not just about the treatments they have.
Okay, thank you, John.
So I think people have the right to know.
Okay. Coming back to Nadia. Nadia, I also know that you work in an international women's organization called Zonta International. So we are constantly empowering women and girl child. So as a woman, do you not think that from that platform we can do something for women's right of treatment or patient right? Can we not make some awareness program, advocate? They have a right to care, they have a right to have a comfort, they have a right to know about the disease.
Absolutely.
Nadia?
Thank you, Zarinappa. Thank you, Zarinappa. I absolutely feel and find that we should generate awareness in our co-female surroundings, friends, relatives, associations in the Zonta, using the Zonta platform, that what should be our right to get the palliative care, and what should be the mm, support service, comprehensive, holistic, like, psychological, financial, mental, and compassionate. These things should be our right, and how we should avail all these right. We should be very much clear about our demands and our mm, what should I say,
Right.
it's our prime right. Actually, we should know about our rights, so we should
It's
disseminate
like a human
among
right.
other co-workers, yeah, through using Zonta platform. Thank you.
Okay, so again, I'm saying we have 500 plus viewers. So today is a special day where we are celebrating the action of the volunteers, of the doctors, the palliative care assistants, the patient, the caregivers who have been in this journey, who have worked tirelessly in giving compassion. Now, this is a platform today, and I want a huge donation from all the viewers and all the speakers that today I'm going to replace palliative care, death and dying with care, compassion, comfort, and you have to promise that I have you have to promise me that you will give yourself 5 to 10 minutes of empathy to your loved ones, to your geriatric relatives, to somebody who's suffering, either via video chat, because in this pandemic, your presence is not, you cannot be present there physically, but definitely a video chat, Viber chat, because the social media should be used for positive things like that, and where if you can boost up their mental emotion, you can boost them up mentally, where they will feel happy, they will think, oh, that person is thinking for me. So that is the donation I'm asking from this platform to all the viewers, to all the speakers, to dedicate 5 to 10 minutes of your time with empathy, and by calling or video chatting or doing a Zoom with your relatives or friends or anyone that you know who is suffering and from a life-limiting incurable disease, or even say who is suffering from COVID. I mean, it also puts you mentally very down. So this is a promise that I want from everybody, because we in this world we are born not only to gain but also to give back something to the society. So we should pledge that this is what we need to give back. We cannot give back huge bunch of money, tons of money, but at least we can give our empathy to someone who's suffering. And with that note, I would like to thank Vikram for arranging this with the pharmacy, with the Palliative Care Society of Bangladesh. I would like to thank Dr. Sneha Rambani. I would like to thank John, who is a good friend of mine, Professor John Robertson, and another good friend of mine, Dr. Nadia Binte Amin, who has really worked hard and working hard for women's rights. And also Many Chu for being the moderator and for allowing this platform so that the viewers can know that palliative and hospice is not about death and dying. It is about quality of life. Death will happen once, not every day. We don't need to die every day. We need to live. We need to be optimistic. We need to be positive. Thank you so much for your time.
Thank you, Zarina. Thank you all. Thank you.
Thank you,
Dr.
thank
John.
you everybody for giving me this platform. It was so eye-opening for me. Thank you so much.
More than
It's very nice and very privileged to share this platform with all of you. Right. So, Vikram, my request, can you share Dr. John's email ID with me so that I can write or drop a letter? We are muted.
Sure, ma'am, will share you.
Yeah. Thank you, Dr. Zarina. Nice to meet you. Nice to talk to you.
Nice to meet you, Dr. Sneha. Thank you so much for being on this platform. Thank you, Nadia. It was short notice, but I missed my mentor, my philosopher, my guide, Professor Nizam. He could not join because he just couldn't connect and he gave up. Next time, inshallah, we'll bring him, and you must see this wonderful gentleman who has made so much of difference in the lives of many, and especially the concept of palliative care in Bangladesh. Vikram,
And hats off to you, Dr. Zarinappa. You are taking so much great initiative, introducing these platform into our country in a wider range. And
yes,
so
we need to know. We need to know. That's why, the day says that we need to amplify this message. My care, my comfort, my right. This is all mine.
Exactly.
Let's put it our right, our comfort, our care.
Yeah. Thank you,
Definitely,
Appa.
Dr. Zarina. Definitely.
Would you like to
Thank you, Vikram, and Sneha,
Thank you, ma'am.
Any questions that needs to be answered?
Nee. Thank you, Nee.
Thank you, ma'am.
Yes,
Okay,
ma'am.
thank you so much. Have a lovely day, and promise to take 5 to 10 minutes of your empathy. Donation.
Yes, I would like to share my mother is 82. My mother is 82.
Sure,
I'm staying with her. Yeah, bye.
Yeah, thank you, ma'am.
Thank you, Dr. Zareen.
How was it? I mean, good attendance?